surgery for today and our last surgery. We'll be broadcasting it live as we do all of our surgeries. Our patient has a herniated disc at L5-S1, and we believe her back pain and right-sided leg symptoms are coming from that disc herniation. Go ahead and scroll. Keep going. I'm looking at the MRI once again right now, the other way. Keep going. All right, yeah. And back. One more. One more. Looks good right there. Perfect. So this patient's herniated disc is small, and she has what's called a pseudodisc or false disc. Pseudo means false disc below it. And it's important to take note of that on the MRI, because when you get into the operating room and you're trying to find which disc to operate on, you're using an x-ray machine to localize. And you need to know that there's a false disc involved, so you count properly, because everyone counts from the sacrum up. All right, so I find the sacrum or tailbone, and I go up to the first disc, and that's the L5-S1 disc. In this case, we have a fake disc at S1, S2, between the S1 and S2 vertebrae. Normally, there's not a disc there. But some people, that's the way they're made. It's the way they come out of the oven up there in heaven, and they got a fake disc. So they just try to trick us spine surgeons. All right, let's go to the lateral view, make sure we identify the pseudodisc. Dr. Deuk here, you okay?
Honey, you okay?
All right. We're going to get started in just a minute. Now, I'm going to give you some numbing medicine to make the pain better, but if you feel any discomfort, please just say ouch, okay? Don't try to come off the table and deck me like an Irish woman would. Can you see if she's laughing? She better be. She's Irish, so I don't want to upset her. All right? All right, so I'm looking at the MRI and I see the pseudodisc. It's totally compressed flat disc. I'm looking at the x-ray and I see the pseudodisc right there at the bottom. And then I look up at the first real disc. It's super juicy and fat, tall, and that's L5-S1. And I look at the MRI and I see that same big, tall, fat, juicy disc. So I feel really good about our localization being proper. And I believe that that right there is L5-S1. So we're overexposed, and we need to get the end plate of 5 a little bit better. You're almost perfect. You're about a degree off. All right, there you go. Playing with the image. So do you think we can wag it just a hair? Just a hair. Just a hair. Literally a degree or half a degree. Just to try to get that end plate a little better at bottom of 5. That's the, well, I think we went the wrong way. Let's try the other way. Just a tiny, tiny bit. That's weird. Did you go the other way?
Yes, sir.
Go worse. Maybe go back half a degree. I don't know. All right, let's get started. Let's leave it there. I think you got a little rotation, maybe 1 degree of rotation. You see how there's a double shadow in the back of L5 at the bottom? Just give me a rotation 1 degree. See what happens. It's definitely different. Let's try the other way. I think it's a little worse. Sometimes you just, that's good. That's good right there. Let's just leave that. That's as good as we're going to get it. Okay, that's my hand back here, okay? Now we're going to put you to sleep in a few minutes, but I need your help in the very beginning. I'm going to feel around a little bit, okay?
Can you hear the doctor? Yeah.
I'm going to give you a little injection of some medicine. Now if you feel some pain, just say ouch. Just say ouch, okay? Don't try to get off the table. Just keep your body still, say ouch, and I'll give you some more numbing medicine, all right? Deal? All right. You're going to feel a little stick and burn. That's normal. That's the numbing medicine going in. Just be patient with me. So I would normally have this draped a little further. You know what I mean? Just to about here. Yeah. Just so I can see the slope down. All right. Yeah. So we just doing a little numbing medicine, and I'm trying to palpate for her iliac crest. That's really what I want to know. Is where is her iliac crest? Shot? And she's pretty thin. So we don't have to go very far. Shot? It's a little higher than I want to be. Maybe right there. Shot? Are you comfortable? All right, let me know if it's bothering you at all. Shot? 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 Where do you feel that?
Where do you feel it then? Right there.
In your back. Shot? In your back. In your back.
Yes.
All right. Just want to hear that. Shot? Have you watched me do any of these surgeries?
Yes, I have.
So you know what's going to happen next.
Well, hi.
Hmm? Shot? Where do you feel that?
Right where you are.
Let's do an AP. So we're getting close to your herniation. I'm about 1 millimeter or 2 away. I just want to make sure everything's looking good. You're doing fantastic, by the way. I appreciate you bearing with me. All right, back to a lateral view. So we're sneaking right around your facet joint on the right side, just heading anterior and lateral to it. So far, everything's looking good. There's a little bit of scoliosis at 5'1", as you could see. Where do you feel that? In your back?
Where you are. Wherever you are, I feel.
Shot? Oh. Shot? All right, so now, why are you having this surgery done? Do you know why? Is it your back, your leg, both? Which is worse, your back or your leg? Equal? And it's just your right leg, correct?
Right leg and
Sometimes left. Sorry about that. All right, how bad was that on a scale of 1 to 10? How high did it go? 10. And is that where you typically get back pain? Okay, we found your bad disc. Good news is you get to go to sleep. And when you wake up, your pain will be gone. And I'm going to tell you what town I'm from. My family's from in Ireland, okay? Because remember I told you my grandmother is half Irish. And you're Irish. So I'm going to ask you to count from 1 to 100 out loud while we put you to sleep. I want you to count in Irish. Gaelic. That's right. Can you do it? All right, very good. Keep counting until you get to 100. All right, so her discogram was a 10 out of 10 concordant, meaning typical back pain. So we just confirmed another source of back pain. How long did you have your back pain for? How many years?
just about 1.5.
You never had pain before a year and a half?
Oh, no, my life.
All right, good. So 1.5 years of back pain. We just found the back pain, something that 99% of spine doctors can't do. It's coming from the L5S1 disc. There's a tear back there, you can see it. And we're going to basically fix it with a laser right now. And the procedure is called the Deuk laser disc repair. It's named after Deuk Spine Institute, where it was created. It's the only surgery in the world that is geared towards curing back pain or neck pain if it happens to be in the neck. It is an endoscopic surgery, full endoscopic, transforaminal. Blood pressure is good. This could be a little bit high, but we could probably bring it down. So far, we lost 2 drops of blood. Are we ready, doctor? So I'm making my incision. By the way, this incision makes this surgery not percutaneous. So some people get confused. They think this is a percutaneous surgery. It's not. Percutaneous means through the skin, and it refers to needle-based procedures. We're obviously not doing a needle procedure. The needle's gone. We just did the discogram with the needle, but the rest of the surgery is done with a real incision. All right, so we're advancing our dilator shot to the L5S1 disc. We're at the level of the facet with the tip of the dilator. Now we're going to go through the foramen shot. Now the whole concept of transforaminal surgery I did not create, but it was pioneered by a spine surgeon, Dr. Parvis Cambin, K-A-M-B-I-N. He worked out of Pittsburgh, University of Pittsburgh, and he was the first to do transforaminal surgery, endoscopic transforaminal surgery. He is the grandfather, so to speak. So we all owe him for developing this transforaminal technique coming from the side of the spine. Every other spine surgeon goes through the middle, right here, except for the new lateral techniques where they come from the side. But those always involve much more dissection and fusion usually. We're not doing fusion on this patient. We're just repairing her disc. So you can see the tip of the dilator is right at the L5S1 disc, and basically we're going to enter the tear. You guys can see the tear. That's where all the dye leaked out after I injected it. It's no longer there. Shot. Once I get this dilator into the disc space and get it started into the tear, then I can take the guide wire out, because ultimately the guide wire is going to restrict the movement of the tip of the dilator. Shot. It can actually get trapped. Shot. You can trap your guide wire with the tip of the dilator. You don't want to do that. All right, you see this blood right here? This is the blood we're going to lose for the whole surgery. You see that? It's about, like if you were to get a splinter in your finger. That's how much blood we're talking about. So this is basically, I can't say bloodless, but the most bloodless, the mostest bloodless surgery in the world, the leastest bloody surgery in the world. And then if you're Irish, everything is bloody. Of course I am 1/8 Irish. All right, we need to get my mom on the phone. So, who has a phone? I can't give my mom's phone number to the whole world, so I have to go silent for this. So we're going to go dark for just a moment. All right? And if she answers, just tell her you're the anesthesiologist working with her son, and that we need to find out where our Irish side of our family is from in Ireland. Shot? Oh, she's not answering. She didn't answer for me either, so don't feel bad. All right, I'm gonna. Right? No, she We'll get her later. Okay, thanks for trying. So this is our last surgery. You can all see what's going on here, right? Sean?
Yes, we can.
So we've basically created a path from the outside world to the disc, right where the tear is causing her back pain. And we're going to go fix that tear with the Deuk laser disc repair, endoscopic procedure with a laser, and then we're going to take this metal tube out and we'll be done. There's no fusion done, there's no bone grafting done, there's no implants put in. This is all natural surgery. It's the most natural spine surgery in the world that works. Unfortunately, spine surgery has been taken over by big companies that just want to sell screws and rods and cages and plates, and they're making billions and billions of dollars in profit, and they're scaring people away from having their backs and necks fixed because nobody wants that in their spine, right? So the truth is there's a natural way to fix back pain and neck pain using the laser and the endoscope. That's the Deuk laser disc repair. So we're trying to make people aware of that so they don't have to go through invasive, dangerous, unnecessary surgery. Okie doke. So we're inside the disc. And remember, the first thing I did before we put the scope in was I introduced the dilator into the disc through the tear. Basically, it's called a reduction. You reduce the disc herniation back into the disc. Remember, the disc herniation came from inside the disc, and I just shoved it back in. Okay, so it should be no surprise to anyone that I'm taking the herniation out after shoving it back into the disc. It's still there. You ready? All right. Go ahead and get that, and then let's do the laser. So traditional neurosurgery or spine surgery instruments like the pituitary rongeur, Kerrison rongeur, they don't work with this small space we're working in. We're literally working in a 7mm space. So you need new instruments or tools to do your job. And that's what the laser is for. Laser is the very best tool. That's what the blue thing is at 12 o'clock. That blue line is insulated with plastic laser fiber. How many people think the plastic keeps the laser light energy in the tube? How many people think the blue plastic around the laser fiber doesn't keep the laser energy inside the tube? No answers? All right. The answer is the blue plastic does not keep the laser energy, the light energy inside the glass filament. It's actually, there's a physics principle where light bounces off of surfaces between materials that have different, what's called an index of refraction. So plastic, or glass, which is the material the fiber is made out of, and air or non-glass surface allows the laser energy to basically hit that surface at the edge of the glass and then bounce back towards the inside of the fiber because of the incident angle of the light energy and the index of refraction. It's a physics principle, but it keeps the laser energy bouncing around inside this glass tube until it gets out the end. So it allows us to transmit energy, powerful energy, healing energy from a machine 6 feet away right down into the disc via the endoscope. And notice I'm not just sticking the laser in and just uselessly jabbing it around like jabbing a sword around in the dark at imaginary monsters. I am directing the energy very specifically at very specific things. I'm moving the laser fiber around. I'm releasing herniated fragments that are stuck in here because otherwise the grabber won't grab them. That grabber doesn't have enough force at the end of the grabber. I can't generate enough pinching force to pull out a stuck down herniation. Okay, you see that piece I just grabbed? If I didn't first release it with the laser from the annular fibers that were stuck to, I would not be able to grab it and pull it out. Because even though this thing looks intimidating, because it's magnified, it's really not that big, and it really can't grab you that hard. So I need to first release things, fragments of disc, and then I can go in and get them with the grabber. So the laser is the most important tool. As a matter of fact, I could do this entire surgery with just the laser most of the time and no grabber. So how many neurosurgeons use lasers? Not many, but there is more and more starting to use lasers because we're finding that lasers are very useful for minimally invasive type surgeries. When my colleagues found out I was using a laser 16 years ago, they laughed at me, and that's okay, because I've been laughed at many times in life. It doesn't bother me. However, once these lasers started to be used to take out brain tumors, to take out epileptic foci in the brain, they weren't laughing anymore. So lasers are used to do endoscopic ventriculostomy to treat hydrocephalus. They're also used to treat brain tumors. They're also used to treat other lesions that cause epilepsy. And of course, we're using them in the spine to treat annular tears. That's the Deuk laser disc repair. So the application of laser energy and technology to neurosurgery and spine surgery in general is expanding over time. It's not contracting. And so the people that laughed at using lasers are not laughing anymore, and they're actually using them themselves. Now I just laugh at them because of their stupidity and ignorance and arrogance. Did you have a question?
None for me currently.
Huh?
None from me currently.
All right. So, for my long-standing audience that have listened to me talk for years, perhaps, you may think that I'm a negative and bitter person. And if you do think that way about me, understand one thing: I am a product of my society. I can't take responsibility for my own behavior, my own mood. And for those of you that admire me, well, I'll take full responsibility. All right, no questions, huh? So if you're watching and you're wondering what that shiny metal thing is, that's the tube that we put in to do the surgery. There's little bits of pink granulation tissue intermixed with disc herniation, the blue stuff, nucleus pulposus, very scarred up. It almost gets so smooth on its surface because of all the inflammation. Think about a rock that someone throws into a river that's real coarse on its surface. And after the rock has been acted on for years within the river by tumbling around and having the effect of running water moving over its surface, bringing sand to shape the surface of that rock, the rock becomes smooth. And it looks like what we now know as a river rock, right? River rocks are smooth. Well, these pieces of disc herniation are also smooth because they've been acted on not by water, but by inflammation, constantly at their surface, constantly trying to get rid of them, like a foreign body, like a splinter of wood in the finger, constantly having inflammatory cells attack, having inflammatory chemicals like that material contained within the lysosomes of polymorphonucleosides or neutrophils. Those are all extremely damaging enzymes. So all that stuff has been working on the surface of this herniation, the nuclear herniation, causing it to smooth out over years. Okay? Now this patient's had pain for 1.5 years. I'll bet you this disc injury is far older than a year and a half. Look at the golden color here in the scar tissue. That's all dystrophic calcification. And all that thick white stuff is scar tissue. That doesn't happen in a year and a half. That takes 10, 15 years to occur. So she may have only had back pain for the last year and a half, but her injury to her disc is far longer and far older than a year and a half. It's probably somewhere around, if I had to guess, at least 10 years old, maybe longer. Maybe 5, 10 years old, somewhere in that range, but certainly more than a year and a half. So she had a annular tear with a disc herniation that underwent scar tissue from chronic inflammation, but she did not have much pain. That's because the inflammation occurred below the surface of the annulus, below where the nerve fibers are. So she didn't feel it, basically. But it was going on, standby for a long time. I'll put it into your hand. Just put your finger out, and that way you don't have to grab around for it.
We have a question.
Yeah, there's one of those pieces of herniation I was telling you about right there. Smooth surface that's been acted on by the inflammation for a long time. Yes, what's the question?
Over here from Periscope wants to know, what is used to help seal the annulus? Is it heat?
Great question. What is used to help seal? There's the granulation tissue as well. What's used to seal the annulus? The annulus is not sealed. That's the one downside of this surgery. And I'm changing that in the next few years. And I can't discuss it right now yet because it's something I'm patenting. But there will be a way to promote that annulus to heal much quicker that I will be rolling out soon. Soon is a relative term. Could be in the next 6 months or 12 months, could be in the next year. You'll see it if you pay attention. So there is no way to get the annulus to seal during surgery. The techniques that are available don't work. There's sutures that don't work, and there's closure systems that don't really work, in my opinion. And so this will heal itself. It doesn't need anything man-made or artificial to be put in here to heal well. However, if there was something that would promote the healing faster, then it would be something that I would want to use, as long as it doesn't have a negative side effect on the patient in any way. The problem is, every time researchers try putting things inside the disc to get it to function better or heal anything structural, it always squeezes out after surgery when the patient stands up. The weight of their body pushes it out, and then it pushes on the nerve, which is right next to where we are, and then the patient gets leg pain. So whatever they tried putting in always ends up just squeezing out and not staying in. So what I found in doing so many of these, over 1,000 of these surgeries, is that you don't need to put really anything, that the patient's disc will heal fine as long as they don't lift things heavier than 25 pounds for the first 6 weeks. And then after 6 weeks, I let them lift up to 40 pounds, not over 40, for the next, for the year, for the first year. If they just follow those instructions, then 90% of the time they won't have a reherniation or a problem. But there are a couple of patients that they tell me they follow the instructions and they still have had a reherniation. It's very rare, but it does happen. And for those people, I can't tell you why it happened, but no bending for 6 weeks and no lifting over 25 pounds. That's the best thing a patient can do to prevent re-injuring the disc and letting the annulus heal itself over time. This will heal completely over time. It just takes a year to fully heal. The reason that this takes so long to heal is that it's relatively avascular. It doesn't have a very good blood supply, and you need blood supply to heal. Okay, so we can't give the disc a blood supply. you could try to put a piece of muscle graft or something in there, but it's going to push out. And then it'll push on the nerve and the patient will have leg pain. And then it'll cause inflammation and scarring and they'll have worse leg pain. And then they'll hate you forever. So you don't want to put just anything in there, okay? There's really nothing man-made that I trust to work. I just want the patient to follow my instructions of no heavy lifting and no bending at the waist, and then let the disc heal. After a year they can do whatever they want. It's basically back to new, okay? All right, just about done. I need 30 seconds. And doctor, it's a pleasure working with you. I'm very happy with the patient's care. I'm very disappointed that my mom hasn't answered the phone, so I can't find out where we're from in Ireland, her family. We were talking earlier, this patient is Irish, and she wanted to know where my mom's side of the family is from in Ireland. So I'm going to find out. Mom, if you're watching, I'm trying to reach you. Okay, that looks good. Laser off. Let's see if we can see the nerve. Once again, I've been thwarted today every time because the nerve is always covered by fat, which is normal, by the way. That's what you want to see. All right, we're done. And we're going to show you folks this incision. The entire surgery was done through a 7mm incision. Scope off. So come on over and take a look. Great job, everyone. All right, can you see this here?
Yes, we can.
Looks a little barbaric, but it's a lot better than open back surgery where you have to drill away bones and joints and ligaments to get down to the disc just to take the disc herniation out. And with open back surgery, nobody repairs the annulus like I do. So the only way to do an annular repair is endoscopically, like you just saw it. I'm going to put a little pressure, and then I'm going to show you the incision. Now, we lost about 2 drops of blood. So again, this is a quote-unquote bloodless surgery. There's no blood loss. We've never done a blood transfusion. We've never needed to. And in 15 years of doing these surgeries, I've had 0 complications. No nerve damage, no spinal fluid leaks, no infections. The only thing we've seen that's bad is recurrent disc herniation, where somebody will push out another piece of nuclear material, and that's about 1 in 100 patients that have that, 1 in 100. So your chance is 1 in 100 of having a recurrent disc herniation, and I'll tell you that chance goes down dramatically if you follow my instructions, which is no bending for 6 weeks and no lifting over 25 pounds. Take a look. Here's the incision, 7mm. Those are normal fingers. I'm not a giant, so tiny, tiny incision. We're going to put a Band-Aid on that thing and we'll be done. Now, go ahead and type up your question. I'll come and answer it in our little interview. And when we're done with the interview, we're going to go check on the last laser, and we'll have him do an interview for you and tell you how he's feeling before he goes home. Thanks, everybody. Great work today. We'll be back on Thursday with 3 more laser surgeries.
All right, everyone, thank you for joining us for the last post-op Q&A of the day. If you have any remaining questions for Dr. Deuk, type them up now in the chat, and we will ask them. For now, I'm going to hand the microphone over to him, and he'll recap the surgery you just watched.
Got a hippo here. So we just finished Deuk laser disc repair, and now we get to talk up close and personal. The surgery went well, you know, with the only exception our patient was Irish, right? Yeah, but we can't hold that against her. No, it went very well. She had had back pain for the last year and a half. It came from a damaged disc at L5S1. We call it a herniated disc or bulging disc, ruptured disc. There's so many different terms, but it all means the same thing. The containment around the disc or jelly is called the annulus fibrosus. It's about a centimeter thick, and it's made up of these rings of collagen, which is connective tissue, basically stacked on top of each other. About 20 to 24 layers of connective tissue. That material is white in appearance, and normally it holds the nucleus or jelly within the center of the disc, so the nucleus can be a shock absorber or cushion between the bones. The problem happens when the annulus fibrosus actually tears, and the tear is, you know, there's tears that can occur in the front, the middle, or the front of the disc, the side of the disc, or the back of the disc, okay? So hopefully, can you guys see this okay, Sean? It'd be nice if somebody held my mic for me. Do you mind doing that? All right, hold it right there. Now, is this looking okay on the camera? Yeah. So these are the bones. This is the disc or cushion. This is the front of the disc, the side of the disc, and then, of course, the back of the disc. So when people have a herniation or tear in the front of the disc, you can't feel that. It's painless. When you have a tear in the side of the disc, you can't feel it. It's painless. Only when you have a tear in the back of the disc, like you see there's a herniation right there. That's jelly squeezed out through the tear. Only when you have a tear back here can you actually feel it. And the reason for that is that this is the disc, okay, I took it out, and there's a little herniation in the back there. The reason for that is that the fibers that carry pain signals from the front and from the side of the disc, they don't carry it to the part of the brain where you can actually feel pain. They carry it to a part of the brain where the pain signals go to subconscious areas of the brain, and they can affect things like, you know, how fast your bowels move your poop through your bowels, or you basically your visceral functions. You know, maybe your blood pressure will change a little bit. You won't even notice it. But when you get a tear in the back of the disc, now that's innervated by a nerve that carries the pain information up to what's called the primary somatosensory cortex, okay? And for those surgeons that are neurosurgeons or spine surgeons or orthopedic surgeons, basically the parietal lobe, right, in the front of the parietal lobe, the foremost gyrus has all that somatotopic organization of pain and sensation. And so the somatic afferent nerve fibers in their somatic afferent, because they project to the primary sensory cortex in the parietal lobe, they become somatic afferents, meaning they carry localized pain. So you can actually feel that pain. And that's why people with sharp back pain, okay, that pain is coming from a structure that has somatic afferent innervation, SA innervation, okay? And SA innervation always goes to that strip of brain where there's a little homunculus, which is the miniature man, and basically the projections of those nerves, those pain nerves, go to different parts of that gyrus, and depending on whether they go medial or central or lateral, it maps out to different parts of the body. And there is a part that maps out to the lower back or to the neck. And so those somatic afferent projections up the spinal cord and to the brain through the thalamus, okay, they actually get to areas of the brain where the patient goes, oh, I can feel that, it hurts. And so they can localize their pain. They'll put their finger right on the disc, right where the disc is that the pain's coming from. And we use that in the assessment of our patients preoperatively to figure out which discs are causing their pain. Now, I can't tell you precisely L5S1, L45 based on where they're sticking their finger on their back, but I can tell it's L45 versus L23 because I know where the L23 disc is, and they're not pointing at it, okay? So we use the physical exam, somatotopic localization of pain, very precise localization of pain from patients to identify which discs are causing their pain. And when we go in with the laser, basically I am debriding or cleaning up the back of that disc, this part right here, the annular tear and the interposed nucleus. I'm using a laser to clean all that away. And usually it's off to the side. So this little jelly thing is in the middle, but in reality it's off to one side or the other most of the time. So I put my tube in right through here. I think we actually have a model of it. Oh, here it is. Okay, so can you hold the mic again? So this gives you a pretty good idea, right? Here's the disc. This is the front, the back, and my endoscope goes, my tubular tractor goes right into through the herniation, through the annular tear, and into the disc. And then I start using the laser to clean all this out. And I just bring it out slowly further and further out, and I clean all this out with the laser as I'm doing it. All right, so that's what the surgery is. Do we have any questions? You guys know everything, so you don't have any questions for me. That's okay, I accept that. Well, the patient we just finished will be able to go home in about 30 minutes. But the patient we did before her, the gentleman where we went on both sides, he's about ready to go home. So let's go check on him in recovery, and we're going to do another broadcast of his discharge from our facility here at Deuk Spine Institute.